Morning, guys. If you'd like to scoot up so they don't have to yell and we're more collective, that would be great. But thank you for coming in today. My name is Brenda, and I have the distinct honor of introducing our next session. So, from the streets to stability, multidisciplinary care at encampments to reduce unsheltered homelessness. So in this session, we're going to look at how the City of Lawrence is reshaping its homelessness response through strong cross-sector collaboration and partnerships, connecting healthcare, behavioral health, law enforcement, and housing agencies all together. This coordinated approach has actually been shared in Kansas and really nationally, if I'm correct, because they achieved 66% reduction in chronic homelessness in just 1 year within Douglas County. So again, today we have Miss Misty, who is the Director of Homeless Solutions Division for the City of Lawrence. She's going to lead the discussion and share how system transformation and data-informed strategies have strengthened prevention and outcomes. Misty is also joined by Kelby Sanders, substance use disorder outreach clinician with Mirror Inc., and Rebecca Lagger-Dyar, family nurse practitioner with Lawrence Douglas County Public Health Department. So together, they're going to show how multidisciplinary care can turn compassion into measurable change. So please join me in welcoming our lovely trio.
Thank you. Well, like she said, I'm Misty Bosch-Hastings, Director of the Homeless Solutions Division for the City of Lawrence. And I apologize, I have a mint. My mouth gets really dry, so bear with me. Before we get into what we built, I want to share why this work matters to me. My experience with homelessness started as long before I had the job title. As a kid living at Lake Shawnee in Topeka, I wouldn't know till much later when I got into this line of work that I was homeless. I just thought that's where we were living. And then later, as a young single mom, I learned how hard it is to get help when you're broke. It really takes money to get money. When you don't have a car or a phone or a ride to town when you're in a rural area, every single task becomes a mountain. I lived in a small town in Osage County, Carbondale, Kansas. No bus system, no nearby offices. My doctor was 30 miles one direction. WIC and Department for Children and Families were 30 miles the other direction. You start to realize that this problem is not about motivation, it's distance, access, and systems built for people who already have resources. I grew up with a parent who was mentally ill and struggled with addiction. I lost that parent to an overdose in 2005, and so I've seen the cracks in the systems from every side, as a daughter, a mother, and eventually a professional. So that's where this story really begins. I went to work for the Kansas Department for Aging and Disability Services as the Housing and Homelessness Project Coordinator. There I managed programs serving individuals experiencing homelessness who are also battling mental illness and substance abuse or co-occurring. My brain naturally gravitates towards fixing things. So I was constantly taking mental notes. This is why this process failed. This is what would have worked better. And then I had the chance to go on from there and create a housing program at the Topeka Rescue Mission. That was my hands-on education, where I learned why people struggle to stay in housing, how lonely it is to leave a community, even if that community is outside. We housed 160 people in the first year, and only 2 households out of that group ever returned to homelessness. That proved to me that stability, not speed, is the real measure of success. After that, I was invited to take on something bigger, leading the City of Lawrence and building a system that could actually change the trajectory of homelessness on a very large scale. This presentation isn't about just one program. It's about what happens when a community stops asking, how do we get people into our services, and asks, how do we bring services to where people are. Because this didn't happen by accident, it grew out of a community commitment. Our community recognized that housing, equity, and health are inseparable, and that's where our story took off. It's always these things, right? Oh, I had it upside down. My bad. It was me. um, when I came to the city of Lawrence, what I inherited was horrific. There was an outdoor congregate setting with no services, no safety, and no plan. It was meant to start to solve homelessness, but it created chaos, daily overdoses, sex trafficking, assaults, and several deaths. It had to be closed. So at the same time I was tearing down what didn't work in this encampment, I was also building something entirely new, without a manual or a roadmap, but a very clear purpose. I was hired and they said, okay, you're the expert, go do the thing, and we did. So I was tasked with turning our community's vision into actual coordinated homelessness response system that is accountable, compassionate, and built to last. The foundation for this work came from our Douglas County Community Health Improvement Plan, we call it our CHIP, where housing, equity, and health were named as the top community priorities. From that led to what we call a place for everyone, and that's the county-wide strategy to end homelessness. It looked really good on paper. Implementation was another thing. When I got there was a misunderstanding. It said, we want you to achieve these goals. So I was like, all right, got started. And they said they had our next, I think we had like 6 months was our next convening. And what I didn't realize until I came back was I was only supposed to map out how I was going to achieve the goals, but I had already started. I had like several checks off of things that were needed to be done. And I was like, oh, okay, well, we're ahead of the game. So that was it was a learning process. I'm just a doer, and it made sense to me. And not why wait 6 months to talk about it. Implementation, my charge was to take the goals, turn policy into practice, build relationships, write procedures, find the right partners, create accountability systems, all while showing up in the field to understand the reality, what was happening on the ground. Started kind of small and then continued to keep adding to what the individuals sleeping outside needed. What they needed was a substance use clinician to do assessments in real time. Peers who were in recovery themselves and are now reaching back out to help others. Staff involved with lived experience with the justice system. Recovery coaches, housing specialists, veteran service specialists, harm reduction specialists, and benefits specialists, and a family and mental health nurse practitioner. In a belief that if we treated homelessness as the public health crisis that it is, and not just a housing issue, we could actually move the needle, and we did. And to show you what that looked like up close, I want to introduce Becky. She is the medical backbone of this work.
Hello, I'm Becky Lagger-Dyar, so I am a dual-boarded family and psychiatric nurse practitioner. So I got into this work because I wanted to help people locally and be able to provide mental and physical medical care to people that were often overlooked or forgotten. So people weren't dying because they didn't care about their health. They were dying because the system had failed them. When I first started going to the encampments, it wasn't homelessness that I saw. It was untreated disease. There were infected wounds, people had blood sugars that were so high that they were having physical ailments because of them. I saw people trying to detox on their own with no medical intervention or help. People who weren't able to get any medical help, even if they needed it in times of crisis. So the suffering wasn't hidden, it was just ignored. We were watching preventable illness take lives every single week. So that's when I stopped seeing this as a housing crisis and started calling it what it really is, which is a public health emergency. When we built our field-based medical care model, everything shifted. We stopped asking people to come to us, and we came to them. We started meeting people where they were, literally. So not just figuratively. So literally meeting them where they were in that exact moment. So we began showing up, in the woods, under bridges, in parking lots, wherever they were. That's where we were going. So we brought the street medicine to them. We also brought a substance use clinician, and then, like Misty had said, we brought peers with us who had lived experience with incarceration, substance use, homelessness. We didn't wait for someone to come to us. We showed up and we built that rapport until they trusted us and they were ready to engage. But we showed up. One of our biggest breakthroughs was medical respite. For the first time in the area, hospitals were able to discharge people to a safe indoor place. They weren't just giving them a bus pass to the streets. So that way they could recover indoors, they had medical check-ins, and they were able to actually follow a care plan that would help with their physical and mental health. So the single shift, treating housing as part of healthcare, it really changed lives overnight. Our vision for health equity isn't just a theory, it's a daily practice. So we measure success in better health outcomes, increased mental stability, fewer ER runs, safer discharges, and stronger relationships within the community. When someone trusts us enough to show us their wounds that they've been hiding or not wanting seen, that's a win. When the hospital calls us before discharging somebody because they want to send someone back to the street, they don't want to send somebody back to the streets and they want to send them to medical respite, that's a win. So our aftercare team keeps people connected, they'll manage medications, transportation, follow-up appointments, home visits, whatever the patient needs. So, because the thing is, it doesn't matter how you treat somebody during a crisis. What matters is how you treat them through the whole process, including aftercare, because aftercare is just as important. This is what health equity looks like in practice. And so the clinical reality, Now Misty's going to show us how we built the structure that made it all possible.
So our outreach operations start like a mobile command center every morning, but that mobile command center is really fueled by compassion. Every morning our team meets to plan routes using the commitments that we made with those that we're already working with to help them complete paperwork, get to appointments, and just remove barriers to getting housed or into shelter and improve overall health. Additionally, we offer a tool to our community where they can go to our website and report someone that they feel might need our assistance. And we get these reports in real time. It has a GIS locator. It pinpoints exactly where they interacted with this person or where they observed this person. This is the first compassionate connection that we get to make to start the process of healing. Additionally, with this same data, we are able to keep inventory of every encampment that's ever been mapped and stay connected with individuals experiencing homelessness, whether it's someone new or someone that moved to avoid us, which happens quite frequently. But we get them eventually. We don't send people out with clipboards. We send them with purpose. Who needs a follow-up? Who needs Narcan? Who needs to be reminded that they have a treatment bed date coming up? Who's due for Medicaid re-enrollment? We log every encounter in HMIS, the Houseless Management Information System, so that anyone in our network can get an overview of what services people are receiving from our team in real time. Kelby handles the assessments right there in the field, and this is huge. This is a systematic barrier that angered me for many years. I would see somebody be ready for help, and then what that would mean is they would get an appointment for a phone call, and then maybe in a week or two, they would get an assessment over the phone, and then maybe in a month or two, they would get a bed, and then by that time, they were high, and they were like, oh, I don't need it, I'm doing good. So that is what I went to MIR with, and that was my first conversation when I wanted to partner with MIR was, is it legal for us to have these assessments done outside? And he says, yeah, we can do that, and then, we can bring them back here and put them in treatment. So that partnership has opened a fast track for us because we get the assessments done, and then we also have the opportunity that if other individuals don't show up for their bed date, we have somebody ready to go, we can call and see if there's a spot, and we can slide somebody in there. And I lost my place. Let's see, so oftentimes we're connecting people with detox or some residential treatment pretty quickly, maybe on average 2 days to 2 weeks-ish, just kind of depends. And then we also have Stephen, our benefits specialist. He gets people enrolled in Medicaid, food stamps, and we're working on Social Security as well. This is a coordination that feels really human. Let's see. Not upside down. Oh, yep, upside down again. Guess it just makes more sense to me that way. So the results that matter. I'll try not to cry. In 2024, 2025, we saw results that proved compassion can be measured. For the first time in at least 20 years, no one in Lawrence died last winter due to exposure from the winter. Over 20 years. It was a rough time for us, and we were at it until March when winter finally ended. But it was worth it to know that we were able to make sure everyone stayed alive. And then we also, from January 2024, January 2025, according to the point in time count, we reduced unsheltered homelessness by 63% in 1 year. Thank you. We also reduced overall homelessness by 30%. So those numbers really don't mean much without the people behind them. So I'm going to have Becky tell what this looked like through the medical lens.
Okay, so medical-wise, there were 239 medical or psychiatric visits for 84 different people. And like I said before, when I say we showed up where the people were, literally. I mean, I've seen people in tents at bus stops. I mean, I've done IV fluids at bus stops, in parking lots. Wherever the person was, that's where we went. So some of the things, wound care, infection management, medication stabilization, whatever the person needed, whether it's physical health or mental health, we were there and we took care of it. So, it's just a continuity of care that was working for us. So, every data point is a person who finally got care and was set on a healing journey. And that's the real story. It's measured in lives, not just numbers on a spreadsheet.
Morning. My name is Kelby Sanders. Before I get into a bunch of information on our stuff, I would like to kind of share a little bit of why I do this work. I'm the outreach clinician for MIR and on the HRT team. I have a strong desire to help individuals that have the similar story that I have. I grew up in Leavenworth, and by the age of about 14 or 15 started dabbling with drugs and alcohol. By the age of 20, I think I was full-blown on meth and heroin on a daily basis. I did not have very many options where I lived, at least none that I was aware of. Nobody reached out to me. I didn't know what to do. My family was constantly trying to find support. Failed therapists, failed social workers, whatever the situation may be. A lot of this is my part, but a lot of it was the limited resources we had out there. So at some point, I had gotten a connection to Heartland Radak and set up a time to do an assessment, which was, like we said earlier, sometimes these are scheduled out months out. And it was scheduled out, I think, 2.5 months from the day I called. And with my luck, Leavenworth County picked me up and sat me down for a few months. And I was able to get out and do the assessment and almost immediately go to treatment. It was within 10 days of being out. That was still relapsing, in between. But when I got to that point and got to treatment, I learned the value of these peers and the work that we've done. And somebody in there who is today not this boss, but my other boss. Oh, I'm not skipping on to that yet. So I met this individual, and he saved my life. I credit him with saving my life because I was ready to leave treatment. He talked me into staying. And at that point, I realized that this is what I want to do for others, and this is the kind of work I want to do with my life. I want to be a counselor someday and do all that, and I'm licensed to do so at this point, but I also would much rather do the peer work and meet with individuals where they're at. That's where I think the real connections exist. Covered a lot of that already. So at first, we started going to the camps on a regular basis. We had a couple established camps. When I started, it was in September last year, and we had a large encampment directly behind our offices. And we would literally walk out the back door of the office and head right into the woods out back and meet with about 40 or 50 individuals that were staying back there. It was difficult at first. There was a lot of pushback. This was obviously a very new system, and there was a lot of mistrust or distrust. And it was hard to earn somebody's trust that had been burned so many times. And it's not just that, but if I reflect back to where I was when I lived on the streets, I don't think I would have trusted right away whether I had been burned or not. What did help is when I would run into people that had been through what I had been through. So I would share that, and a lot of times I would get, I don't care what your story is. But over time, as we continue to meet over and over and over again, the same faces, the same people showing up day in and day out, and there's no judgment, we would continue to build trust slowly. In the last year, we've had a 30% engagement rate, which is 3 times the national average. As of Monday this week, I have completed 50 assessments for 50 unique individuals. 25 of them have gone to treatment, 15 of them have completed treatment, and 12 of them have become permanently housed since leaving treatment. So what that tells me is that housing and recovery is possible if it's accessible. Next slide. So, as I said, a peer in my life saved my life. I was dead set on leaving treatment and going back to the streets and doing what I used to do. I'll give a brief understanding of what happened. Somebody at treatment talked me into believing that I was not really an addict. And I told them to pack all my stuff. It is time for me to leave. I very happily took him to the door of the cafeteria and I said, "Do you see all these people in here? They're really addicts. I am not an addict." And at this point, he decided to take me aside and asked me why I came. I told him I would like to look good for the judge. He asked me what these things are going on that I'm going to see a judge about. And I said, well, I like to rob and steal things. And he said, why do you do that? And I said, to pay for dope. And he very kindly explained to me that I might be an addict still. But it was the first time anybody had actually sat there without judgment on all this and very kindly put it into words that just because you don't fit their cookie cutter version of an addict or a cookie cutter version of mental health doesn't mean that you couldn't benefit from this. So I decided to go full force into it. We've got many peers on our team. Christy's one of them. We've got Jeff and Tanya and Raul. But we bring peers in from MIR, and I began my work in this profession as a peer. So a lot of my work is very much peer-focused. Everything I do in outreach, I try to address as a peer. I only do the clinical stuff when we sit down to do your assessment, and even that becomes very, very... I remember how difficult it was to do my own assessment and how worried I was about the person sitting on the other side judging me. I put it out there that I've been there, I've done that, I've walked in your shoes, I know what you're going through. Anything you're about to tell me right now is not going to shock me, okay? And we just have a conversation. I can typically turn our assessment into a quick conversation, hour or so long, and I get to know you, and I've gotten the information I needed, and I'll see you later on this week. When someone who's lived it says you're not alone, people believe it. Okay, I think that I'm not good with notes. Okay, so we try to take a lot of the medical and the behavioral health information that can be difficult for anybody living on the streets and living in addiction or anything of that sort, and explain it in a way that we can receive better, a little bit easier. We try to show up, as Becky said, we are there all the time. We will go meet you wherever you're at and provide the services, but when you have to go somewhere and we have to get services somewhere else, we always are there to help out. We provide transportation, and we try to be as available, both emotionally and physically, as possible for these guys so that they know that we're here from beginning to end in this. We calm chaos, and we prevent relapses, and we rebuild trust. We do prevent a lot of chaos. We calm chaos a lot. So there's a lot of, we've all taken trainings in de-escalation skills. We try not to get directly involved in things, but we know the population that we serve. It can get very stressful at times. And before there are outbursts, we try to get involved and help calm things down, at least play a little bit of a mediator at times. And shared experience, not policy, turns engagement into healing. Next slide. So the model works because we all work together. We've got members of LMH, the Lawrence Memorial Hospital, the Health Department, MIR, RADAC, Heartland Community Health, Mobile Integrated Health, which is awesome, and The mobile integrated health team is, I guess, kind of similar to Becky, but they're like more like crisis. They're paramedics. Yeah, they're paramedics. So like when things are like really out of our hands, they're the first people we call to get something taken care of right there in that moment. Meet some medical needs that may be way beyond our scope. And then we have the Homeless Resource Center that we partner with directly. We make it a daily stop. This is open to the whole community. Anybody that is homeless, or whether you are or not, you can come in and visit. But we make a point to be there for about an hour or two a day. We meet most of our clients there that we've met already throughout the day, and we follow up on things that we were working on earlier in the day with them at the end of the day. Meetings are focused on names and not the numbers. We try to focus on the individuals and how we can help them, who on the team can help out with whatever situation. It's great to brainstorm on individuals rather than just focus on what our numbers are and how many people we've engaged with. I couldn't tell you how many people we engage with on a weekly basis, but it's probably upwards of, 60 to 100. So it would be very difficult to be focused on numbers anyways. The question isn't who owns this case, but who can help the person today. Becomes part of structure instead of like, whatever.
You did great.
Did I do great? Okay.
Best team ever. Best team ever. So what we realized is when collaboration became our culture, then we were able to get really innovative. And one of the big things that we have done is we have closed all of our major encampments. Like I said, when I got to Lawrence, there was an encampment that had over 125 people. And my task was, you are responsible for all things emergency shelter and homeless outreach. So when I got there, there were 25 emergency shelter beds open and about 400 homeless people. So pretty quickly, we created the Pallet Village. It's a 50-unit non-congregate shelter. The Pallet is a brand name. If you're not familiar with it, it's just a small house, and 2 people can stay in it. So we created that gated community. We invested heavily in the Lawrence Community Shelter and moved them from 25 beds to 125 beds. And then most recently, we were able to create a low barrier shelter, and so proud of that. And that really rounded out our ability to make sure that people had choice. And not everyone would fit in, what we had, just, in one system. We needed multiples. So creating that space allowed us to then close this encampments. And it is a big push. We are kind of freshly off of our last closure. It was actually 2 camps, probably around 50 people or so. And these folks we had kind of chased around from place to place, building that relationship, building that trust. And then, but these folks were our most ill, for sure. Our most ill in the worst parts of their addiction. And we had chased them from this camp, and then we would close. And so we just kept building the relationship. But finally, when we had a place where we could say, you can go, you can take your partner, you can take your pet, you can take your drugs, you can put them in this special little box over here. It truly is a low barrier in every sense of the word, and it's what we needed to do the work that we're doing. So when we built this system, it wasn't a pilot. We were building it for permanence. Since we started, we integrated GIS tracking into HMIS so that every outreach note, service, and map pen feeds into a live system of accountability for us. It means that we can literally see who's being reached, how often, who's waiting, where the gaps are in real time, so no one slips through the cracks anymore. Every week, our team brings everyone to the same table. Health, housing, sometimes law enforcement, to review real cases and make real decisions. Beyond that, we have a program we call Familiar Faces. So this is decision makers from every helping agency. We're meeting to figure out what support someone needs and how to wrap the right supports around the people who need them the most. Kelby briefly mentioned mobile integrated health. We have 2 paramedics, and Becky also is part-time on their team, serves with them. So these individuals respond when firefighters and paramedics see the same names and realize that these folks don't just need emergency attention right then, they need something, some more supports. And so we get a weekly high utilization list from that, and just like, hey, here's who we're working with that really needs supports, can you talk to them too? And just the system keeps going. Also, we have a new group, crisis systems operations team that's being built out right now. And this is where, in this room, you'll have our judge that handles like our drug court and our mental health court, our district attorney, myself, Douglas County, the heads of MIR and RADAC and all the partnering agencies that serve the individuals experiencing homelessness. And we are together to coordinate to make sure that people that are in crisis get the right care in the right place at the right time. Financially, we've made it just as durable. Braiding, we do a lot of braiding local funds, investments, opioid settlement funds, special alcohol funds, writing grants, to make sure that this isn't something that fades when the headlines do. We've brought 8 Narcan vending machines online in the last 2 months, and it's been amazing as well. That's what innovation looks like when it's built with accountability. It doesn't burn out. It becomes part of how a community takes care of its own people. So my advice is start where you can. Make it actionable and universal. So if you're trying to apply this to your areas and thinking, our town would never go for this, we can't do this, they would never buy into this, start small. Look at your EMS or emergency room data, find the top 10 repeat utilizers. Those are your first clients. Pair a nurse and a peer, go to them, and then track what happens. Don't wait for perfect. Perfection is the enemy of progress. Start with what you have, measure it ruthlessly, and adjust fast. That's how you build momentum that becomes a movement. So for us, this isn't just outreach anymore, as you can imagine. This is public health. When we stopped waiting for people to come to us and start meeting them where they were, everything changed. When I got there, this was the way that things were done, that lovely phrase. For many, many years, we had given a agency too much money to sit in their offices and tell people, if you want help, you can come see us. And it took somebody 20 years to realize that that didn't work. But this is, when we changed that, health improved, housing stabilized, and deaths stopped. We haven't fixed homelessness. We are treating homelessness. We built a system that finally sees the whole person, body, mind, and most importantly, their story. The 63% reduction wasn't luck. It was proof, and that data and compassion are not opposites, they're partners in change. So before we open it up for questions, I want you to hear from Becky and Kelby on some personal stories, because this work lives in these stories. So Becky, my question for you, what's one moment that still reminds you why you do this? You can microphone there, or you can stand. Okay.
It's always nice to end on personal stories, right? You know, just those feel-good stories. And the one that definitely stands out the most for me is we had someone who was released from a psychiatric hospital to the streets, and had no support, zero support. So when he first got there, we saw him a couple of times, and he was okay and was making do. And we started seeing him deteriorate, because no support. So there's nobody, you know, checking in with him, making sure he's, you know, taking his medications, making sure that, you know, he's eating, nothing like that. And so as a team, we said, all right, to be able to help this person, because at this point he was in full psychosis, and was, you know, seeing things, hearing things, and was very disorganized and having a very hard time. So as a team, we said, all right, let's do some intensive outreach with this person. And again, we showed up, and he started recognizing us and got to the point where he was coming to us, and he was remembering names. They weren't our names, but he was calling us names, you know, good names, you know. so we were like, all right, well. And then he agreed to start taking medications. And so every day we would ask him what he wanted as far as food. And he would tell us he wanted a veggie tray and a little container of jalapeno ranch. And so that's what we would get him. And we'd show up, we would give him his veggie tray, and we would talk and we would visit. And he would literally drink the jalapeno ranch like it was a drink. But after that, he would take his meds. And he got stabilized. And we were able to transition to a long-acting injectable. And he is currently awaiting housing for permanent housing. So.
And I want to say they worked on the weekends too. Like it didn't stop when they got off the clock. Also, Christy had a lot to do with that too. I remember her telling me that when she hugged Henry for the first time, when he was finally open enough, how much that meant to her. And it did not matter to her that Henry probably hadn't bathed in a year or more, and still she cried tears of joy, and that's who our team is. All right, Kelby. What's one thing that you wish people understood about recovery and trust?
I turned it on. There we go. It's on. So when it comes to recovery, I wish that people understood it's not a one-size-fits-all. That is one of the most difficult things to get around, especially in the health field. Everyone tends to believe that if they have no experience with it or don't have personal experience with a family member that's had these issues, especially in substance use recovery, it tends to be just stop drinking or just stop using. And that is difficult to hear. I've watched nurses at the hospital tell me why they're kicking my client out while he's waiting for the bed to open up. And it's because he's been there over 100 times this year for the same thing. But I think if that message is given and gets across enough people, that'll make a change where recovery will be more possible for a lot more people.
Thanks, Kelby. So I didn't plan on sharing any personal stories, but then when I woke up this morning, I had a text, and I almost made it. I can do this. Good morning, Misty. Today is 6 months clean. Oh, shit. Only by the grace of God and people like you. You're an amazing lady. Thank you. Thank you. That person, 30 years homeless and in prison, and came to us in the winter, and one of our team members connected with him, and he said for the first time in a long time, he felt like somebody cared. And that led to his recovery. And also, it led him to my church. Showed up one day at church, and he's there opening the door for me, and looked like a completely different person. And I think Christy introduced me to him there, and I didn't recognize who it was. And that's what we get to do. Those are the things that we get to do, and it's just really a blessing. And so that's how I want to close this, with the voices that keep this work real. Thank you. Okay.
Yep. Is it on already? Thank you. So as a nurse, what really struck my interest is a medical respite program. Can you explain a little more about, like, physically where that is, and like who staffs it, how it's funded, things like that? Because I think that's something that would be really important to a lot of people here who are in the medical field.
Yes. So several years ago, it was a project through architect students at KU, and they built 12 units that were supposed to be used for family housing behind the Lawrence Community Shelter. The units were not taken care of. They were, but there was still good bones. So I invested in getting these up to code, and some of them are ADA. And what prompted that is one of our staff members lives next to the hospital. She came outside one day, and she saw an elderly man in about 100-degree heat, wearing paper pants that had urine and feces all over them, and a hoodie, and he couldn't breathe. And she tried to push him to the hospital, and they came outside and said, "No, he's not welcome here." And so, me being me, I emailed the CEO and said, "Do better," and figured out what my part could be in that, because I don't wait for other people to figure out a way if it's going to take too long, because these are lives. So I talked my friend, the executive director of the shelter, into letting us use those for medical respite, and we are building it as we go. We require, I do the reviews of the applications and set the requirements in place. Somebody has to have at least 3 visits a week from someone in the medical profession. A lot of times it's visiting nurses, but if they have behavioral health, we also require that mental health provider is in that unit as well. And sometimes we are the provider if it's somebody that we know. Getting them there will help with our next steps. If they have those, they still have to meet eligibility criteria, but it's been a great tool to have. We don't see elderly people on the streets anymore, like we did in that sad condition. We're not very far. Yeah.
I
Okay.
was just curious with your pallet community, how long are people allowed to stay?
It just depends on if they're actively working. So we have two. So we have one that's a bit of a high barrier. It's in a neighborhood next to a child daycare. So that one we put in rules: no sexual offenders, no violent offenders, things like that. So that one, as long as you're working your goals, meeting with your case manager, and truly trying to exit homelessness, it is what it is. I think on average, when I was at the Mission, it was about a 6-month process for people that kind of had it together to get into housing, and not everybody has it together, so it could take longer. The nightly shelter for the low barrier, whatever they need. They are invited inside to participate in programming and kind of see, like, okay, this is a little bit nicer in here and we get more food, and we're just kind of hoping that they'll gravitate inside and start that programming and then seek out Kelby services more and things like that. Christy, you already know the questions. I mean, the answers. But thank you for asking. I appreciate your participation.
So an interesting fact that I want to support Kelby with is, one day I came into the office and he was really struggling. And he'd get them assessed, he'd get them to treatment. 2 days later, they were gone, and he was just really having a rough time. And I said, Kelby, it looks different. When your bottom's already in a tent, and so statistically we know, 7 times, average person 7 times to treatment. And I dug a little deeper and I said, Kelby, do you realize if somebody is unsheltered, the average times to treatment is 16 statistically? And Kelby's like, wow. He was getting pushed back from the higher ups. He was, and I was like, Kelby, it's going to take some work. We can't give up now, So I just wanted to
Thank you.
add that.
Yeah, thank you for adding that. There is a lot more barriers, and we got to remember we just got to keep pushing to remove the barriers. And Kelby likes to do things right the first time, so he's learning. I was going to add something. Now I forgot. Because of that fact that we found out, we've kind of been exploring what it might look like to have a small treatment center for individuals experiencing homelessness.
I have one question. You talked about your data sharing in your HMIS, and so I know especially that mental health data and substance abuse data is very protected and things like that. So I'm just curious, how freely is that data shared, and how did you overcome those barriers? Because data sharing among healthcare and CBOs is like, no, it's my data, no, it's mine. I mean, how did you overcome that, or did you, and what lessons have you learned?
So what we share are services, very vague services. So if somebody goes to a profile, there's going to be a page called services, and if you click on that tab, you'll just see every service that person received from a program. Becky has her own program, and it's I don't remember what it's called, non-ESG something. So the folks we work with, they know who's Kelby's the outreach program. Then we have an aftercare program where we stay with people for at least 1 year after we house them. And so it might say something like offered water. There are notes that we can put in there, but not everybody can see our notes. Sometimes we can make things public, but we do not put any PHI in that. She has her own EHR, right? That she keeps that kind of stuff because we don't really need it for the purpose of what we do. We collect services only.
Any other questions? Okay. Well, thank you so much for a great presentation. There was great questions, and I'm thinking that there'll probably be some more for you throughout the day. So looking forward to that. Would you be able to advance to the next slide?
Oh, yeah. If I could, maybe.
I figured